Thank you very much, and thanks to the organisers for inviting me to join your fantastic panel discussion today. My name's Louise and I'm a clinical staff specialist, sexual health physician, and the president-elect of the Australasian chapter of sexual health physicians. Thanks to Rose and the organisers for inviting me. I begin today acknowledging the lands on which I've prepared my slides of the Nipaluna and the Palawa Pakana people, and the lands in which I'm presenting, which is in New South Wales and the Gadigal land, and paying my respects to the elders, past, present and emerging, and to the respects to the First Nation people of your lands as well. So I think you've been through the notifications in New Zealand, but we're particularly interested in the late presenters and getting to zero. And thank you to the preceding speakers for mentioning this as well. So like Australia, a majority of our notifications in Australia and New Zealand are in men who have had sex with men, may be gay identifying or not. But importantly, in your AIDS epidemiology group dashboard, it is reminding clinicians to test for HIV in people who where there does not appear to be any apparent risk factors. And how can we raise awareness around that? And particularly looking for these people who have a late presentation, as their care costs a lot more, there's onward transmission, and of course there's higher morbidity and mortality for those people. So we appreciate the opportunity to get towards zero. So, So of course the goal is to be talking to our colleagues in other areas of medicine, including ED, as Ed mentioned, and raising awareness around clinical indicator conditions and supporting colleagues and clinicians to test, normalising HIV testing. As you said, the opt-out HIV testing in emergency departments has worked, and harmonising the guidelines across specialties to remind clinicians to test for HIV. As you'll be very familiar, the HIV clinical indicators, the number 1 and 3 are very obvious. Conditions which are AIDS defining. People come to hospital with a pneumocystis pneumoniae or a Kaposi sarcoma, but what about if they come with esophageal candidiasis or cervical cancer? In the third group, this is with our colleagues starting immune modulators and chemotherapy agents. And overall, I think that's being done fairly routinely, although sometimes there may be a risk assessment there where it's Mrs. So-and-so from a low prevalence background, and so maybe she doesn't get the testing, but I don't have evidence for that. But most importantly are these clinical conditions that it's a background association of greater than 0.1%, where again, as Ed said, it is cost effective for us to test for HIV. And in Europe and the British HIV Association, it has been the norm and recommended for a number of years. And of course, ASHM has been on board with this, and our chapter Sexual Health Medicine has this high on our work plan for the coming work plan lifespan, as well as our national strategies. So again, these conditions include conditions that are presenting to general practice and emergency departments, like undiagnosed diarrhea, persistent thrombocytopenia, leukocytopenia, unexplained weight loss, lymphadenopathy, or some AIDS-defining illness as well. So these are quite common conditions. How can we increase the testing in those patients when clinicians may be going, but this is a heterosexual man who doesn't have any risk factors? So we have examined the guidelines and found that whilst there may be mention of HIV association, very few of them specifically recommend HIV testing, and this was some work done at Monash University. And we know that clinicians' ability to detect the risk factor or perception of risk may be unreliable, and also many of these patients are presenting late and may be unaware of their own risk. So our call to action is to rule out HIV in these medical conditions, recognise cases early and reduce transmission. So we need to help clinicians. Some have been stung by the you need to do pre-test counselling, and we need to encourage our colleagues to be saying to the patients, in this situation, it is normal that we would rule out HIV and give them the language to use. So, so far the tests have been negative. We routinely perform a diagnostic workup, and this includes a HIV test for everyone. This reduces the need for the clinician to do any sexual health conversations, which can be awkward, but it can also be met with a, no, I haven't had any risk, which may in fact be true. So we have noticed these missed opportunities for HIV indicator testing and reminding our colleagues that we're wanting to rule out HIV and that no counselling is required. And so in Australia, our tests are Medicare rebatable at a cost of $15. But again, when it comes to talking about HIV opt-out testing in emergency departments, overall there is an agreement that that should be a great thing to do. But when it comes to who should pay, there seems to be a stall. As you hopefully are familiar, we've developed with ASHM this clinical indicator-based testing tool, which has got a condensed version of the opportunities where HIV testing should be recommended. And on the flip side of the tool, it's put into systems to assist the clinician to say, okay, well, I'm a neurologist. Let's think of all the times when we need to be doing HIV testing. And what about our colleagues in dermatology, where recalcitrant seborrheic dermatitis or psoriasis are indications for testing to rule out HIV. So I guess our call to action is to align the routine testing with guidelines and policies, to normalise testing and explain the rationale for testing. One step further, in Europe are certainly ads to consumers about getting HIV testing, about knowing your status. We haven't done those campaigns for the general population, but maybe that's something to think about. And I guess just to tell you what we've been up to at the moment, certainly working with New Zealand and Australia with the GP health pathways, which is a great opportunity to ensure HIV testing is recommended in any of the clinical indicator conditions. The College of Physicians, we've met with a number of the societies and specialist colleagues to promulgate HIV indicator testing across their jurisdictions. And we're also meeting with other colleges such as the College of Pathologists, Emergency Department. What about med schools? In all the conversations, that just really currently depends on local champions, but maybe we'll be able to do an audit of what testing is happening in our workforce development, but that's a bit of a long shot. There is also looking at revising the therapeutic guidelines to include HIV clinical indicators and collaborating with the guideline owners to include HIV testing. All this takes time, and until we normalise or make automate testing, I think it's very hard to have the piecemeal education that might might change a few behaviours, but not across the board. Of course, it's easy for us who work in sexual health clinics. We have the patient has Googled us and come in, they're ready for HIV testing, but it's much harder for our colleagues in general practice who've known the patients for a long time and may be worried about raising the question of HIV testing. So I really appreciate the opportunity to speak today and congratulate you on the panel on the meeting, and like to thank my colleagues who have assisted with the preparation and the team at ASHM, of course. This is how people get to the sexual health clinic in Hobart. So thank you very much.